Okay, so I think we'll get going. So welcome everybody to this seminar. I'm really excited. We have two fantastic speakers today in aid of World Suicide Prevention Day later this week. Without wishing to take any of their time, I'll quickly say that we have deliberately put together two speakers who are from very different disciplines, very different perspectives, to have some lovely dialogue. So what we'll do is have Leah Quinlivan first, followed by Amy Chandler, and then we'll have 20 minutes of questions for both of them or one of them, but so we'll get a bit of dialogue going at the end. And that means that if you could please put all the questions in the Q&A, the chat function is disabled, but stick them in the Q&A and I will pick them up. If you could put them, if they're to one or other of the speakers specifically, put who it's to, or otherwise I will address them to both. So first of all, I'm delighted to say we have Leah Quinlivan. She is a research fellow at the University of Manchester. There she is on screen, hey. She leads the self-harm research component and co-leads the patient involvement and engagement work in self-harm and suicide prevention in the NIHR Greater Manchester Patient Safety Translational Research Centre. That's quite a mouthful. I had to read that off the paper. She's also, however, an expert content advisor for the NHS England and NHS Improvement funded programme to improve community-based services for self-harm. And she's going to talk to us about self-harm and the central role of psychosocial assessment for improving patient safety in emergency departments. So Leah, if you're ready, I'll hand over to you. Thank you.
Okay, brilliant. Thank you very much. I'm going to share my screen. Just 1 second. Okay, so hopefully that looks okay for people. So today I'm going to talk about self-harm, patient safety, and I'm going to try and highlight the important role of psychosocial assessments for helping to improve patient safety. First of all, I'm going to talk about suicide and suicide prevention. Then I'm going to talk about patient safety. I'm going to highlight why self-harm is a key patient safety concern. Then I'm going to move on to psychosocial assessments and kind of put forward some potentially workable solutions to help improve patient safety. Okay, so we are well aware now that suicide is a globally public health important issue. There are around 800,000 people each year who take their own lives. In England, if we take, for example, a 10-year period, so from 2007 to 2017, there were over 65,000 people who took their own lives. Around a third were patients in mental health services. Self-harm is common in people who die by suicide. And if, for example, we take women under the age of 25, around 88% have a history of self-harm. Around a third have sought help for self-harm to 3 months prior to their death. Now, it's really important anytime we talk about numbers and we talk about statistics in this area, that we remember that these are people who have very tragically lost their lives. So these images here are from a public engagement event that I had the great privilege of being involved in a long time ago when I was doing my PhD in Dublin. It was a collaboration between art and science. The scientist was a guy called Kevin Malone, and the artist was Seamus McGuinness. They worked really closely with families to create these visual artworks. And the aim was to bring forward the identity of the person and remember the lived life as well as the lost life. And it's always stayed with me. And I think it's important that we remembered those lived and lost lives and that suicide can be preventable. Suicide prevention strategies, so locally and internationally, recognize people who are in contact with mental health services and those that have harmed themselves as key intervention groups to lower suicide rates. Health services have a really important role here, and one of the things that they can do to contribute to suicide prevention strategies is help to improve patient safety. When we talk about patient safety though, what do we actually mean? This is a screenshot from NHS Improvement, and they define patient safety as the avoidance of unintended or unexpected harm to people during the provision of healthcare. Some classic examples that we tend here are if somebody had an operation that was intended for somebody else, or in the wrong part of their body, or maybe they went to the dentist and had the wrong tooth taken out. But what about in mental health services? There's greater use of seclusion and restraint of the Mental Health Act, complex overlaps between the Mental Health Act and the Mental Capacity Act. Then there is, of course, stigma. Stigma associated with mental health generally, and particular issues such as self-harm. So the contexts are very different, and it's likely that the avoidable harm is different too. So we looked at that. So we analysed data from the National Patient Safety Agency from 2014 to 2019. And these bars here represent different reported patient safety incidents. So these are defined by NHS Improvement. And the colours represent different trust types. So we have, for example, mental health trusts and acute trusts. And what we can see is that there are some patient safety incidents that are common across services, so irrespective of service type. So for example, medication errors and patient accidents. But mental health services have very specific issues. So disruptive aggressive behaviour and self-harm. Let's look a bit closer at patient safety in mental health services. This is again from data that we analysed from the National Patient Safety Agency. There are a number of different areas that we could and very much should focus on. So for example, incidents of assault and aggression are likely to have profound and potentially detrimental effects on people. However, self-harm is the most commonly reported incident and the one most likely to result in death. Therefore, it is a key patient safety concern. We also know that rates of self-harm are increasing. So this is a paper that was led by Sally McManus and colleagues, and it was published in the Lancet Psychiatry in 2019. And what they demonstrated was the rising rates of self-harm over time. This is particularly prominent amongst young females. Now, some people think that self-harm is just an issue amongst young females. It's not. Our colleagues have also found rising rates in midlife. So this is a paper that was led by Dr. Caroline Clemens, and she found rising rates that were associated with alcohol and with economic factors, but also the rise in self-harm was associated with a rise in suicide rates. Then Kathy Morgan and colleagues, rising rates of self-harm in older adults, and they were also more likely to die by suicide when they did harm themselves. We also know that unfortunately self-harm is strongly associated with suicide. So this is a study that was led by our colleagues in the University of Oxford. And what they demonstrated was the particularly high risk of suicide immediately after hospital presentation for self-harm. Okay, so we know that self-harm is a key patient safety concern and strongly associated with suicide, and an important issue in and of itself. So what can we do? We know from our colleagues in the University of Oxford that there are around 200,000 presentations to hospital services each year for self-harm. So that's a key opportunity for intervention. One of the things that we know helps when people present to hospital having harmed themselves is a psychosocial assessment. So this is an interview with a clinician, and it's usually an evaluation of needs and of risk and looking at the reasons why the person had harmed themselves. We've fairly good evidence now to recommend psychosocial assessments and for their benefits in helping to reduce repeat self-harm. And clinical guidelines recommend that all people who present to hospital having harmed themselves should receive a psychosocial assessment. But in practice, things are a bit different. So this is a study that was led by our colleague, Dr. Jane Cooper. So Jane looked at services for self-harm in a randomized sample of 32 hospitals in England. And she found, amongst other things, really variable rates of psychosocial assessment. So some were as low as around 22%, some were a bit more up there, around 88%. We know from quantitative studies that the average rate for psychosocial assessments is around 50–60%. So what we have then is a very consistent and persistent rate of non-assessment. So people coming into the hospital with self-harm and then not receiving a psychosocial assessment. One of the reasons why there might be this gap between evidence policy and practice may be because we don't adequately understand the context of what's happening in services. So that's what we wanted to do in the Patient Safety Centre in the University of Manchester. We wanted to build on our already existing work, but we wanted to really try and close this implementation gap. So we designed a series of studies. So first of all, we had a patient and care qualitative survey. Then we had a multi-site hospital study where we went around to over 30 hospitals and spoke to over 50 clinicians. So what did we find out then about this context? So let's take the people who come into hospital and they have sought help for self-harm, but they don't receive a psychosocial assessment. So this is a very vulnerable group of people at risk of further self-harm and suicide. And this is from our patient and care qualitative survey data. And it was published, this paper was published recently in the Australian and New Zealand Journal of Psychiatry. Okay, so we found the reasons for non-assessment fell into three broad categories. First of all, we had patient reasons. So this was reasons for refusing or leaving before an assessment took place. And then we had these organizational circumstances. So somebody might want an assessment, but then they didn't get through this gateway to have one, or else they didn't reach this kind of clinician determined hierarchy of risk. So let's look at the patient reasons for refusing an assessment or leaving before an assessment took place. Now, these will be fairly familiar to people. Okay, so people said that they left because of long waiting times. Some people said they had to be medically cleared, which added on to the waiting times. People talked about waiting in environments where they didn't feel safe physically or psychologically. This added to already distressed emotional states, and people just wanted to get out. Other people left because of negative interactions when they were waiting in the emergency department or previously when they attended mental health services. Some people felt the assessments were pointless. They weren't going to speed up access to aftercare, psychological therapies. So what was the point? Other people said it wasn't what was needed at that time. So it's not that they didn't need support, they did, but maybe it just wasn't the right time to talk, or they had to go to another appointment or go to work or pick up the kids. And then two people, small number, but really important, they refused because they wanted to die or they wanted to self-harm again. So this is a quote, and I'm going to read it out because it might be easier for when you're looking at the presentation. And this person said, "When we have waited for hours, my family have decided it's making things worse. So they've taken me home, even though they didn't feel it was safe to do so." Okay, so let's move on to the gateway issues. Okay, so this is when the person might have wanted an assessment, but they didn't get through to this gateway to access liaison psychiatry. So some people said they didn't receive medical treatment, so then they didn't get access to liaison psychiatry, or they weren't offered or referred for an assessment. One person said they didn't even know it was ever a possibility. Other people talked about the assessments being dependent on how busy the department was. The more busy the department was, the less likely they were to have an assessment. Alcohol was a major issue. If the person had consumed any alcohol when they attended the emergency department with self-harm, less likely to have an assessment. One mother talked about her son who was refused frequently for a psychosocial assessment because he'd used alcohol. And then at one point he attended and he'd had a breathalyzer, and then he was sent home in a taxi to his flat, and he ended up taking his own life when he was in 26. Then there was this nuanced issue over communication and capacity. Okay, so having an assessment depended on how the person communicated the self-harm when they attended the emergency department. So if they appeared fine and in control and maybe had capacity, less likely to have an assessment. Or if they kind of described the self-harm as a mistake or said they could keep themselves safe, less likely to have an assessment. So this is a quote from a person who was refused medical treatment. I'm going to read it out again. "I was refused treatment for self-harm and to see psychiatry by an emergency department doctor because the doctor said, 'You're just going to do it again anyway.' So I left the emergency department in distress, only a day out of being discharged from an acute ward very suddenly, with a wound in my leg that was muscle deep and eventually required internal suturing. So there's really clear implications for patient safety. We've already seen that this is a really vulnerable time for suicide risk when someone has been discharged from an acute ward. Okay, then there was this clinician-determined hierarchy of risk. Okay, so if people presented in visible crises, so maybe clear signs of mental illness or hearing voices, or maybe with police presence, in most cases, more likely to have an assessment. But then there was this clinician-determined hierarchy of harm, okay, where suicide risk was kind of the top tier. Self-poisoning fitted into this suicide risk narrative, so it was taken more seriously. Self-cutting and self-injury, on the other hand, were deemed more behavioural and attention-seeking issues, taken less seriously, and the person was less likely to have an assessment. The more medical intervention required, particularly if it was self-poisoning, the more likely the person was to have an assessment. However, very thin line, and if the person crossed it and fell into the narrative of frequent service use and frequent self-harm, more stigmatized response, less likely to have an assessment and less taken seriously. So this is a quote from a person, and they said, if I expressed suicidal thoughts or my injuries had been on certain parts of my body or severe enough to be classed as a suicide attempt, they'd receive an assessment. In A&E, unless you're close to or have tried to kill yourself, you'll just be sent home. Okay, so what about the people who did receive an assessment then? What was happening for these people? So again, this is based on our qualitative patient and care data, and it was published recently in BMJ Open. Okay, so people again will be fairly familiar with these responses. So what helped? What helped when people attended the emergency department having harmed themselves? So humanizing care throughout the process from the time the person arrives in the hospital, collaborative assessments, actually having space and time to talk, compassion and reassurance that the person did the right thing in coming to the emergency department, and then receiving help, so receiving practical help from the assessment. What didn't help? We've already seen the implications of long waiting times, environments where people don't feel physically or psychologically safe, but also stigmatizing attitudes from the time the person comes into the hospital, but not just from the acute team, going through to liaison psychiatry as well, the whole process. Then coercion and control. So this is when people might attend with police, but also when security guards are used for monitoring. Tick box assessments, intense and invasive questioning, and then repeating information when it can be looked up online. What I want to show though is the implications of this process for patient safety. So this person here is talking about the psychosocial assessment, okay? What I'm trying to illustrate here is when people have had more positive experiences, they were less likely to harm themselves. The harm was reduced. So this person said, after the assessments that were more caring and humanizing, I tended better to my injuries and felt less self-hatred. They were still deeply upsetting and difficult experiences, but I was more likely to be able to take steps towards self-care and getting help, and also less likely to self-harm in subsequent days. On the other hand, though, people who had more negative experiences throughout the process, it was likely to increase their level of harm and likelihood to further harm themselves. So this person is talking about the psychosocial assessments, and they said, I felt that there was no room to explore what was actually going on, that I was given little opportunity to express myself, and the whole process was a bit of a tick box exercise, rather than a supportive conversation or way to come up with a helpful suggestions. 9 out of 10, these assessments left me feeling worse. Okay, so what can we do then? How can we improve patient safety in this context? Okay, so of course we have the NICE guidelines. Okay, so these are the quality standards for the NICE guidelines that were published in 2013. They're a set of standards that we would expect good quality services to have who are caring for people who've harmed themselves. Number one here, people are treated with compassion, respect, and dignity. We shouldn't have to say this, but you can see why we still do. But let's bring it directly to psychosocial assessments and what we can do here. Okay, so many of these issues could be helped by side-by-side working between acute teams and liaison psychiatry. So people may be aware of this consensus statement. So for example, in hopefully reducing those waiting times or removing barriers with having to wait until the person is medically cleared. Also opening the lines of communication from a very early process. We know from our own research and lots of other research, the importance of really listening and engaging with people meaningfully and non-judgmentally throughout the entire process. Our data suggests support workers can be really helpful. And also, when people do have to wait, that they can wait in an environment where they feel physically and psychologically safe. So what about gateway issues? So this is where the person might have wanted a psychosocial assessment, but then they didn't get through this gateway to kind of access liaison psychiatry. We've been to some hospitals and they have pathways for people who've harmed themselves. So somebody comes in and then if they say that they've hurt themselves, then they're on this pathway. Maybe that could help catch the people who are falling through the net. Obviously, there's huge issues with stigma and culture change that need to be addressed. But then there's communication and education over how communication can be affected by stigma and previous negative experiences in mental health services and by distress. That's particularly important for administration staff and acute triage staff. Alcohol. We know that alcohol is a major issue and that around 50% of people who come into hospital with self-harm have alcohol as part of the episode. We just exclude these people. You're excluding a really vulnerable group of people for risk of further harm and suicide. I know in some hospitals they have a dual diagnosis staff as part of the liaison psychiatry team or alcohol specific staff, so maybe that could help. For the people who do leave the hospital before an assessment takes place, I know some hospitals have a follow-up service where they will phone the person and they'll try and arrange the assessment for a different time, so maybe that could help. Okay, so what about this clinician determined hierarchy of risk, this hierarchy of harm? We know from a lot of research now about the association between more dangerous methods of self-harm and suicide risk. However, we cannot predict risk by method alone. There's a lot of evidence to indicate that people switch methods, often to a more dangerous method, which they might die from. And there's evidence to demonstrate the association between self-injury and self-cutting and suicide risk. And that self-injury and self-cutting, particularly when combined with other methods, are than self-poisoning. So irrespective of method, of motive, of suicide intent, consistent with the NICE guidelines, all people who present to hospital should receive a psychosocial assessment, or at least be offered one, and be taken seriously. And we need to also challenge the assumptions around frequent self-harm and service use. This is another vulnerable group of people for risk of further harm and suicide. Okay, so I'm going to end now and I'm a minute over. So thank you very much and I'll stop sharing. And I'd just like to say, actually, for the assessments paper, Amy was a reviewer on the paper, and I would highly recommend people have a look at the reviewer comments. We had a very excellent dialogue throughout the process, the review process. And Amy, thank you. You really helped to strengthen that paper. Yeah, so, okay, so thank you very much for listening. And I'm really looking forward to your talk, Amy.
Thank you, Leah. That was amazing work. I'm sure there'll be loads of questions afterwards. So next up, we have Amy Chandler, who I'm particularly appreciative because this is her second talk of the day. So in this crazy Zoom live, that's a sterling effort. Thank you very much, Amy. So Amy is a sociologist and senior lecturer at the University of Edinburgh, and she leads two amazing projects actually on addressing the social, cultural, and kind of political understandings of suicide. So one is Suicide Cultures, which is reimagining suicide research, which is funded by the Wellcome Trust. And the other is Suicide in as Politics, which is funded by Leverhulme. And so I'm going to hand over to you, Amy, if that's okay.
Absolutely. Thanks, Anna, for inviting me. Yeah, thanks, Leah, as well. I really enjoyed working with you on the paper that you just referenced and look forward to some chats when I've finished this. Right, I'm going to go ahead and share my slides. Hang on. Okay, hopefully that's visible and works okay. So a bit of a key change for you all, I think, as Anna mentioned, Leah and I, although we have much in common, I think, work in sort of slightly different ways. So the title of my talk today then is Being on the Edge, Urgency and Inevitability in Community Narratives of Suicide. What takes us to the edge and what does it feel like when we're there? In this paper, I'm going to be spending some time thinking with you all about one particular metaphor that has recurred in early pilot work for an ongoing study, which is seeking to understand how culture and social contexts shape and make up suicide in Scotland. This is the Suicide Cultures project that Anna mentioned and is funded by the Wellcome Trust. In focusing on the metaphor of being on the edge, I'm not making any claims about how suicide is understood in Scotland as a whole. I'm not suggesting that being on the edge is a master narrative or a dominant or even a key way in which suicides are made sense of and understood. Indeed, the broader Suicide Cultures project is seeking to explore and spend time with a much wider diversity of understandings of suicide. Following Jack Douglas's interpretive sociology of suicide, I think that what suicide is, how it's made sense of, how it's practiced and measured, is certainly not the same everywhere. In the Suicide Cultures project, we're exploring whether there are any patterns to this diversity, and we're asking questions about what suicide is to different people in different places. Jack Douglas was a sociologist writing in the 1960s and who spent and grappled over an entire book with the meanings of suicide. In his work, he was developing an approach to understanding suicide that would diverge from the dominance of Durkheim's legacy. Durkheim, very famous sociologist of suicide, some of you may have heard of. Douglas found himself dissatisfied with the basis on which Durkheim's infamous typology of suicides was based. He questioned the official statistics around at the time of suicide and noted that death and its meaning couldn't be easily extrapolated from such official, often questionable statistics. Douglas argued there was no objective truth to suicide. Instead, he advocated a more Weberian approach to understanding suicide, which, for the non-sociologists among you, requires a focus on meanings, on interpretation, and makes a place for necessary imaginary leaps for an empathetic treatment of suicides, which understood them in context. Writing many years later, Avery Gordon, another sociologist, grapples with similar questions. Gordon wonders how, as sociologists, we can study things that are felt and unseen, what Gordon refers to as ghosts and hauntings. Gordon's ghosts are not just shadowy apparitions, spooks and ghouls. Gordon's ghosts are, I think, exquisitely relevant to thinking about suicide, to considering the spaces left by those who die by suicide, and the challenge that those of us left behind have in making sense of the death and the loss. It returns me and takes me to the challenge of suicide prevention, a desire that things might have been otherwise. Gordon's ghosts include the legacy of slavery in the United States. Gordon's ghosts include considerations of poverty, which she reads through literature, doing a close reading of Toni Morrison's The Bluest Eye, which talks about the importance of furniture without memories. Gordon's ghosts offer a way of thinking or wondering about social structures, about culture, and about how these are experienced and felt, delicate questions with powerful effects, effects which move some of us closer to death, sometimes by our own hand. What both Douglas and Gordon's writing underline is the importance of hearing stories about suicide, perhaps, within social, cultural, and historical contexts, of not assuming we know what is meant, but of also making space for us, researchers, observers, scientists, to face the limitations of our own imaginations and of what we can claim, to acknowledge perhaps that there is no truth. For me, suicide is a compelling illustration of some of the challenges faced by social and other scientists in studying the social world, a world that is complex and is often a moving target. It doesn't stay still. And yet, with suicide, this is a subject matter that often struggles with uncertainty. perhaps because ethically and morally suicide is so heavy. There is a continued desire in suicide research for precision. We see this in attempts to demarcate suicidal from non-suicidal self-injury, for instance, or attempts to underline or distinguish between a real suicide attempt and a suicidal gesture. And we saw some echoes of this in Leah's talk just now. Some of these ideas about a suicidal gesture, for instance, might sound unfashionable to some, but again, as we saw in Leah's talk, these things endure in clinical practice. They endure also in everyday understandings of suicide and self-harm. And we hear this in talk of attention seeking or descriptions of self-harm or suicide as pathetic, cowardly, selfish, or in other contexts, suicides might be described as being a serious act. Someone really meant it, or you have to have some balls for that. So in the rest of my talk this afternoon, I'm going to be focusing on a different and particular metaphor that recurred in early pilot work for the Suicide Cultures Project. And this is this metaphor of being on the edge. In the early pilot work, myself and my colleague Sarah Wright were trying out what we called arts-based discussion groups in order to explore diverse community understandings of suicide. We worked with 3 different communities, but in the presentation today, I'll focus on data generated with just one of these, and it was a largely white community-based mental health organisation located in a semi-rural small town somewhere in Scotland. 16 people had come along to our information evening about the project. And so rather than turn people away, we'd offered 2 groups of 8 people, a series of 3 to 4 art sessions where they would have an opportunity to explore with us different understandings of suicide, talking and making art as they chose. Why were we doing this, you might ask? Why not just do some interviews or focus groups, or maybe even a survey in order to explore community understandings of suicide? A good question. Over the last few years, with colleagues Sarah Wright on the Suicide Cultures Project and Zoe Sumapolo on an earlier study where we looked at an arts-based study of self-harm, I've increasingly been attempting to experiment with arts-based, or what Bach and Purwar would refer to as live methods of research. As I've discussed in some of my earlier work on self-harm, which drew on narrative approaches, self-harm and suicide, I'd argue, tend to attract comfortable, increasingly well-worn stories. And these are incredibly important to think about and to think with, but I had begun to wonder what the point was of doing more qualitative research, gathering similar stories. I wondered more about what role sociology and social science, or suicide research in general, could or should have in making space to shift stories, to tell different stories, perhaps to transform understandings. I knew this happened anyway, to some extent, especially in the type of qualitative work that I'd done before, which involved unstructured, collaborative interviewing. My work with Zoe, though, had suggested that introducing arts practices to the research process much more explicitly seemed to open up further ways of telling different stories, allowing for greater space for imagination and playfulness. Each of these things, Victoria Foster has argued, can and should be central to sociological practice, particularly when we might have aims towards social justice, to working collaboratively with participants, with communities, and to collectively reimagining social worlds. For our sessions with the Community Mental Health Organisation, we focused each session around a particular theme. This included gender, talking about suicide, seeking help, and what helps, as well as discussing the themes of the week and occasionally making use of the arts materials. The participants in each group spent time in our sessions discussing wider aspects of their lives and the life of the community. The majority of those who took part in these groups had direct experience with suicide. In most cases, this was their own experiences with suicidality, whether it was attempts, plans, or thoughts. In other cases, it was the loss of others, experiences of suicide bereavement. And of course, for some, these experiences were not mutually exclusive. For the sessions, we split the kind of each group of 8 into 2 smaller groups, one who would sit with Sarah and one with me. The discussions were recorded with permission. And in each case, we brought with us some themed prompts to start or perhaps provoke a discussion. For instance, in the week on gender, we brought along an infographic about suicide rates between men and women, along with contrasting statistics about rates of self-harm among suicide among LGBTQ+ people. We also brought kind of quotes which had instances of how researchers had attempted to make sense of the difference between men and women's suicide rates. And in this case, allowed participants the opportunity to sort of speak back to the research, speak back to media guidelines about suicide reporting, for instance. Conversations flowed easily. Some group members already knew each other, others didn't. But the space was used to question, to reflect, to share stories, whether shared or personal. Some participants also took up the available art materials to sketch out ideas or just doodle as a way of kind of managing sometimes quite intense discussions. Across the multiple conversations and engagements that we had with each group, Sarah and I developed a deeper understanding of the lives of those who took part and the routines and rhythms of life in the community that they each in some way belonged to. For several participants, some of the stories they told were of ongoing, very current, very pressing troubles. Almost universally, these troubles were related to financial pressures. This was one of the places where the metaphor of being on the edge was employed. And so I'm going to work in the next couple of slides with this particular example to show something of what we can do to understand metaphors in social and cultural context, and to read beyond and into what participants tell us in order to imaginatively connect individual stories with broader social and cultural contexts. So in one of our sessions, Marshall, one of our participants, turned away from another participant they'd been talking to and said, "Sorry, I was just saying I never got PIP, which is the personal independence payment, a form of benefit in the UK." She said, "So I said to the woman on the phone, well, what am I meant to do? Because I've lost my job." And she was like, "Oh, go to the job centre." And I was like, "You cheeky cow." At this point, Jane, another participant, continued the conversation with Marshall. Jane reassured Marshall that the person on the phone was clearly not doing their job properly and should have offered more help. She then went on to offer some help herself to try and support Marshall in working out the intricacies of applying for different benefits. At this point, though, she stopped herself and looked to Sarah, my colleague who was sitting with the group at the time, and said, "I don't know, it's nothing to do with this." And Sarah said, "Oh, no, carry on," as she reassured her. Jane continued then. Well, so she said, "Well, if you go on to universal credits, then you can get put on ESA," because Marshall interrupted and said, "See, I'm on nothing." Jane says, "Well, so you go to the job centre and get your doctor to get a sick line." Marshall said, "I've got a sick line." Jane says, "Well, okay, so you put that to the job centre and then you'll get universal credit, but then there'll be a letter like the PIP one, the big form, but you get the worker here to help you fill it out and then send it away, and you'll get another appointment like the PIP appointment, but it's not, it's a universal credit appointment. They'll get you put on the ESA." Marshall was visibly deflated at this point and just said, "I just feel there's just no point." Anyway, she turns again to Sarah. "I'm sorry, I digress." Again, Sarah reassured and repeated, "It's not irrelevant." I want to draw attention here to Marshall's suggestion that her tale of ESA, universal credit, job centres and PIP is not relevant and was a digression from our discussion of suicide and help seeking. Similarly, Jane's suggestion that this was nothing to do with this, and Sarah's repeated reassurance that these conversations were not irrelevant. Later in the discussion that day, this group talked more about what help might be useful if for people who are at risk of suicide or who are in distress. And they suggested that more access to counselling would be good, that teaching kids in schools about how to cope with their emotions or talk about their feelings might be helpful. However, directly after Marshall's discussion of her PIP woes, the group went on to relate the following, drawing on the metaphor here of going over the edge that had been introduced in an earlier week's discussion. Participant 104 kind of reassured and said, "Well, I'm the same. It's like when you're going through this, all you want is for somebody to pick you up and say, 'I'll deal with it.'" And Jane agrees. She says, "Because you can't cope with it." And 104 says, you can't process this. And it could be like that girl like last week, "I couldn't find my bus pass and it tipped me over the edge." And at this point, participant 104 broke down laughing. And Marshall says, "Yeah." Jane says, 104 says, "And it could get at that level where it could be anything. Anything, yeah, it could be the slightest thing and you're just upset. It's the straw that breaks the camel's back." In this discussion, these challenges with accessing the resources necessary for life, money, are framed as the last straw, a slightest thing that might push one over the edge, as well as a broader context in which not finding a bus pass could tip one over the edge. There are a few things to notice here. Not finding a bus pass might be more liable to tip one over the edge if one is reliant on public transport to get to places, like a job centre interview, and doesn't have access to ready cash to make up the shortfall. Bus fares in the place where we did this study are just short of £2 per journey. Job seekers allowance in Scotland is up to £74 a week, but you have to apply for it. Marshall was one of the participants who drew something, made some art each time that we met. She enjoyed art, was good at photography. And in our sessions, her drawings were often done on big bits of brightly coloured paper, using dark Sharpie pens to create patterns, threaded with subtle and often not so subtle messages. The week that we had the conversations about PIP and being on the edge, her drawing, which I don't have permission to share in visual form, but I'm going to describe, was a pattern of screaming faces, echoing Munch's The Scream, or perhaps the scream from the spoof horror movies. Threaded through the repeated motif of the screaming faces was a special number that was special and protective for Marshall, as well as the words die, loser, help, voices, checking and fear. I want to finish this short exploration of being on the edge to consider how we might think through this metaphor in relation to broader social contexts outside of the immediacy, urgency and grinding down of the stories of Marshall and many others. We're told that suicide is a public health crisis. We're told that those experiencing suicide are in crisis. In a chapter entitled Slow Death in their book Cruel Optimism, Lauren Ballant argues that the language of crisis can serve to divert attention from slower, more deliberate processes. In the stories that participants told of being on the edge, there was a tension. Being on the edge was undoubtedly something urgent, a state where the smallest thing could tip one over the edge. However, I want to draw attention to the points which participants had suggested were irrelevant. Bus passes, accessing benefits, losing a job. Mental health and suicide are perhaps more often framed as internal problems. Psychology. Someone isn't coping. They feel trapped and hopeless. Maybe they need counselling. Maybe schools should provide more education about managing one's emotions or talking about feelings. Ballant reminds us to look beyond the immediate, beyond the framing of a crisis, whether individual or relating to public health, to consider how one might get to the edge, what structural and cultural processes result in a feeling of being on the edge, and what perverse narratives we have that then blame an individual for getting to a place where they might go over. I think we can and must do better as suicide researchers. However, to do so, we need to not only listen carefully and critically to accounts of lived experiences, we need to be able to imaginatively connect these accounts with the contexts in which they're provided. Crucially, we need to imagine suicide on both an individual and a structural or cultural level, to consider what stories it is possible to tell about suicide and which stories might be harder to hear. Drawing on Ballant, China Mills has argued for consideration of suicides in the context of a hostile UK benefit system that deliberately produces misery and may be understood as knowingly generating suicides. Her analysis, like Ballant's, considers a public health crisis in light of structural drivers and cultural resources, as well as individual experience. There are ongoing inequities in suicide rates along numerous intersecting social identities and positions, socioeconomic status being just one. Suicide research needs to attend imaginatively and creatively with these intersections, balancing individual experience with broader contexts in order perhaps to consider other ways in which suicides and suicide prevention could be otherwise. Missed a slide.
Thank you, Amy, that was amazing. Okay, so we have got about 15 minutes for questions, and just as everybody musters their thoughts and puts them in the Q&A, I'm going to do that cheeky chair's prerogative thing and ask one to both of you. And it comes out of two phrases that you both use. So Leah, you talked about the life lived as well as lost. And Amy, obviously, you've talked about what takes us to the edge. And it got me thinking, like in suicide prevention research and actually in societal discourses more broadly around suicide and suicide prevention, do we think about that life lived enough, about what living life means, and the kind of it, you know, life and its edges, its contexts, its meanings, its struggles?
Amy, I'm going to let you take the lead on this one. No better woman.
Okay, I'll try. I don't want to jump in too quickly. Anna, you might be unsurprised, but I don't think that there is enough focus on the life lived or the edges or the struggles, unfortunately, in a lot of kind of discourse around suicide prevention. I think there is quite often far too much focus on the immediate crisis and of a desire, you know, which is not that it is unimportant. Of course, it's, you know, incredibly important to think about that moment of crisis if it's experienced of such the edge. But I think there needs to be far more consideration of the very long trajectories and deep trajectories that can lead people to the point where they are on that edge or in that crisis. And I think in terms of how suicides are discussed and how suicide in general is discussed, there isn't enough kind of consideration about the lives themselves until they're already gone, and that's deeply saddening, so, and deeply frustrating.
I think when there's also, I think, almost kind of a fear sometimes of discussing the lived life and the lost life. Like the project that I was involved in when I started my PhD, it was a great introduction to medical research because it was completely different. And there was outrage almost at the prospect of a study like this happening, because it directly addressed the anonymity behind suicide statistics, where they had to get people themselves to present to the ethics committee to say, no, we want this identity to come forward. We want this person's life to be known. And those exhibitions, I'm delighted it's still going on, and it's designed as an intervention to address stigma and to address around mental health and around self-harm. But it's a proper aesthetic experience. It's when you go to it, you can't escape it. You can't escape all of the lived life and the lost life. And I think that's why the work that Amy does and why these other kind of engagement events are so important, because it's an essential part of it. It's too easy to hide behind statistics or just focus on that crisis point. So I'm a big fan of Amy's work, you know, throughout it.
Thank you both. I have another one. This came in during your talk, Liz, but you may have something as well, Amy, to say to it. So is there any evidence about the impact of service user involvement in A&E and having people who have lived experience present on site to aid support to the person in crisis? So that was mainly directed at you, Leah.
It's still not, I'm not that familiar at the moment with proper evaluation studies of people with lived experience working as part of liaison psychiatry teams. It's still, it is happening, thank God. There are some, well, sorry, I just said that, being Irish, thank God, I've no affiliation with any God or anything, but I'd like to see it. I'd like to see more kind of research studies of peer support and liaison psychiatry, but I'm not aware of any proper evidence evaluating it compared to kind of a team without it. No. Amy, do you know any?
No, not directly, but I have heard talk of in one very strange context, but I don't know if it's ever kind of played out, about having peer supporters present in kind of like clinical environments, particularly A&Es, as places as being, like a potential alternative or safer sort of space. But I think, but I've not seen any studies or anything about how it's actually played out.
No,
I guess,
I've seen.
Mm-hmm.
I've seen hospitals. I've been in a lot of hospitals, and I've been in some excellent teams where they have really meaningfully integrated people with lived experience as part of the team, and it's excellent. It's really great. But then there are lots of other issues about where does it all fit in? What's the support that's provided to the person, and how meaningful it is integrated? The same with involvement generally. But there are places that do it, and it is becoming more and more common, and more people want to do it. It's how well it's done. That's the thing.
Thank you. And actually I have another one for you, Leah, from the chat, which is a little bit more detail actually around psychosocial assessments. So who does them? And just in terms of mental health teams working within A&E departments, is this a psychiatrist or psychologist? You know, how does this work, I think is the feeling there.
Okay, so the liaison psychiatry around the country, the teams are pretty variable. But for the psychosocial assessments, it tends to be liaison psychiatry nurses and then doctors. Some doctors would do it. In the main part of it, it's liaison psychiatry nurses who do the biggest bulk of the assessments. But you also have some multidisciplinary teams where you'd have social workers or you'd have occupational therapists as part of the team as well. And I saw in the chat about assistant psychologists, you wouldn't really, not that I'm aware of, you wouldn't really have assistant psychologists doing too many psychosocial assessments because of the nature of the assessments and the potential for safety around these assessments. So they'd usually have to be fairly qualified. But what you would have assistant psychologists doing increasingly so is acting as support workers. So support workers in the emergency department, really important role for actually talking to people and having cups of tea and actually providing support, which is often one of the most meaningful parts of the whole journey. So I hope that answers anything. I'm happy to give more specific details about liaison psychiatry structures and formats if the person wants to email me.
Thank you. I got a question from Clara, who would like to say that both of your talks were fascinating and important. I would completely agree with that. But particularly to Leah, have you come across that stereotype that repeated attendance for self-harm means the person has kind of borderline or emotionally unstable personality disorder? As far as Clara writes, that as far as she knows, this cannot be further from the reality of patients or service users' kind of diagnoses and experiences, but are we still stuck in that kind of mindset?
Yeah, and Amy, I'm sure you'd be able to answer this as well. Like for sure, that like sometimes when you mention self-harm, people immediately associate it with diagnosis, which is loads of complicated issues there in and of itself, like with the diagnosis, that's hugely stigmatized as well. So it is a major issue, yeah, and it is unfortunately a lot associated with personality disorder diagnoses, or emotionally unstable personality disorder, and then it's also people who come in and just say they receive a diagnosis, right? Sometimes people don't even know that they have received a diagnosis. Then they come into hospital, and then it's like it's almost an identity, and then they don't see anything else beyond that, and then it's just a stigmatized response then, and the kind of, Amy, I'm sure you could talk about this as well for sure.
Yeah, no, I mean, I'd just to echo really what you've already said, and if, I've more recently done some small bits of qualitative work with people who've self-harmed, and I've been doing small bits of qualitative work with people who've self-harmed for over 10 years now, and I was really depressed that in 2021, still particularly for women, if they're presenting with self-harm, they're getting labelled as having borderline personality disorder, emotionally unstable personality disorder. But the problem with it, as well as the kind of stigma that Leah's just referred to, is the lack of access that then seems to present for some of them for any kind of treatment or support, because they're viewed as too complex for kind of many different kinds of, normal sort of psychological therapies they might get. But the access to DBT, which is the kind of, type of treatment that's supposed to be offered for borderline personality disorder, is not always available or accessible, especially if you've got more than one diagnosis. Then you're really in trouble. But yeah, so it does continue to be a really troubling, really problematic one for sure.
Just to say, we do work very hard to try and challenge any of these kind of assumptions, whether they be explicit or latent, because sometimes people are like, explicit about it, but other people, it just comes out in the way they talk that you kind of realize that they're thinking like that. And one of the great things of being part of the NHS work that we do on improving community services for people who've harmed themselves is we can directly address all of those and challenge kind of those assumptions, which when you're talking about being really frustrated with things, it's good being able to practically do something about it. Well, hopefully anyway.
Thank you. So I've got one for Amy, which is, you mentioned that there's too much focus on immediate crisis of suicide. says Frida. Is there any research that actually maps people's journeys on how they got to that edge? And do you think this can be studied using any kind of quantitative methods in order to understand the scale of the issue?
So yeah, absolutely. I mean, I mean, I guess one of the reasons, one of my entry points to the work that I do is that there is increasingly quite some good quantitative studies which show that people, you know, with, for instance, from particular backgrounds, whether that's sort of socioeconomic backgrounds or kind of, there are different rates of suicide across the different nations of the UK, for instance. Northern Ireland has much higher rates than the rest of the UK, and there are sort of, you know, some sort of attempts to understand that quantitatively. I guess what my work is trying to do is to try and understand those kinds of relationships more qualitatively, so that we're not making assumptions, for instance, about how poverty might be related to a greater chance, a greater risk of self-harm, and to try and understand, you know, some of the kind of complexities of how those different factors play out for individuals in their lives, and in terms of how kind of social factors and social structures then play out into kind of individual actions, meanings, explanations, and experiences. So yeah, no, absolutely, there are people working in kind of quantitative studies that are much cleverer than I am around statistics, that have indeed been able to kind of make some links, but it's then about trying to understand, but why do those links exist? And that's where the kind of qualitative work comes in.
Thank you. And linked to that, I've got one for both of you, which is what do you both think is important in the intersection of health services and structural or cultural factors to improve the way we respond to suicidal presentations? So in a way, how do we draw together your work? Actually, I guess that's asking.
So I'm still working on answering that question. I think it's a really important one, to be honest. I think like one really basic way, and just to kind of build off the conversation just now about borderline personality disorder and assumptions that are made about what self-harm means, and some of the stuff that Leah was talking about in her presentation around what different methods of self-harm are understood to mean, and this kind of assumption that people who are presenting with self-injury or self-cutting are less serious or somehow less of a suicide risk, when, you know, again, the kind of some of the quantitative studies in this area have really problematized that assumption. But I think as well as that, there's a need to better understand how these different practices of suicide and self-harm are understood within different communities, within different cultural groups, social and cultural groups. There isn't really enough kind of qualitative work or work that asks those questions even to really be able to answer that, and to know whether or not that could then be helpful for understanding some of the patterns that we see in terms of self-harm and suicide across different social groups and different locations. So yeah, I'm still trying to answer the question. It's a good one.
Yeah, I think it is an excellent question, and I think both sides are really important, because I don't think we'll ever progress unless we bring in the arts components and we have the qualitative components as well. We're never going to close those implementation barriers unless we understand it, because a lot of these issues are very abstract. You know, like even when you talk about mental health, when you talk about specific terms, they can seem abstract. Whereas you need to, like, say when Amy was talking in her presentation and about the use of art and the use of art materials, it brings things down to a more concrete kind of level. So to be able to understand things more for the full intersection from societal through to health services, you need to look at the full perspective. You need to look at the quantitative to understand those. You need to look at the context about what's happening in health services, the cultures there, all the societal ways, and the very concrete ways of that people understand things themselves and their pathways. So I think it's all essential. Whereas beforehand it was very diverse, and you had people who were just very stuck in one particular zone, and they never read anything else, or they never looked anything else. Whereas thankfully now I think researchers are much more familiar with different disciplines and different approaches, that it can only help us progress, I hope. I hope.
Thank you. I do have a couple of questions in the chat that we won't get to now because I'm aware of time, so I'm sorry to those people who have put those in. But I think between the two of you there, I think that's a fantastic ending. I think it suggests that there's a lot of work to do, but also together you have showcased what incredible work is going on in this area. So all that's left for me to do now is just to say thank you to both of you for being here today and giving us so much to think about. So thank you very much.
Thank you.
I also should say that the next IMH webinar is on the 11th of October with Dr. Senga Dutta from the Cambridge Centre for Teaching and Learning, and we will send out comms around that in due course. But until then, thank you everybody for attending. Thank you very much, Amy and Leah, and have a good afternoon.